Good afternoon.
Good afternoon.
My name is Barbara Wilson, and I would like to welcome you to the Michigan Medicine Peninsula Community Lectureship Series. On behalf of the University of Michigan, I would like to thank Bill and Gretchen Soutier for the sponsorship and inspiration for this series, and Vicki Shirley and the library staff for their help with this series as well. Dr. Chris Bichakjian is a professor of dermatology and chair of the Department of Dermatology at the University of Michigan. Dr. Bichakjian is a foremost expert in the field of cutaneous surgery and oncology. He has a special interest in Merkel cell cancer and established one of the first multidisciplinary programs in the world for this rare skin cancer in 2006. He has presented over 100 national and international lectures and visiting professorships, and he has authored or co-authored nearly 90 peer-reviewed publications with a primary focus on cutaneous surgery. On a national level, Dr. Bichakjian has been heavily involved with the American Joint Committee on Cancer, the National Comprehensive Cancer Network, and the American Academy of Dermatology to improve clinical practice guidelines in cutaneous surgery. He was awarded a presidential citation for his work in this area. Dr. Chris Lau is a medical oncologist and clinical professor in the Department of Internal Medicine and Dermatology at the University of Michigan. He specializes in the diagnosis, treatment, and research of melanoma and other advanced skin cancers. Dr. Lau served as the co-medical director of the Oncology Clinical Trials Support Unit, overseeing all clinical trials in oncology at the University of Michigan from 2016 to 2021, and he continues to co-direct the cutaneous research team. Nationally, he serves on the board of directors of the Big Ten Cancer Research Consortium and on the Cancer Development Grant Review Committee for ASCO, the American Society of Clinical Oncology. His career evolved from developing models for melanoma prevention to focusing on therapeutic clinical trials in advanced skin cancer. His contributions to the field have culminated in numerous practice-changing treatments in advanced skin cancer over the last 10 years. Please join me in welcoming Dr. Chris Bichakjian, followed by Dr. Chris Lau.
Can you hear me?
Yes.
I think you can. Thank you, Barb, for that introduction. Just to be clear, the presidential citation was from the president of the American Academy of Dermatology, not President Biden. I want to echo Barb's thoughts and first of all thank Gretchen and Bill Soutier for sponsoring this wonderful lectureship. I've heard from so many of you that this is, you've been to many of these, so you must be enjoying them. I think it's, we talked about it over dinner last night, it's a wonderful idea to have this lectureship and to provide an opportunity for people like Dr. Lau and me to reach out to communities like yours and answer questions that you may have and share with you what's happening down in Ann Arbor. So it's great. And to all of you, thank you for being here. It's a lovely afternoon. It's always a lovely afternoon here, so thank you for being here. It's nice to have a full house. I hear that this is the highest attendance of all of this series, so I know it's because of Dr. Lau, but it may have something to do with that skin cancer is a pretty significant problem around here. So again, thank you for having us. It's really a pleasure to be here. So this is the title, frankly, that we were given, are we close to a cure? And I guess I'll start off by saying that I think it's important for everybody to realize that we've been able to cure, the vast majority of skin cancers for a very long time. And the reason for that is that most skin cancers are caught at an early stage. I mean, you've heard this so many times. If you catch something early, you can treat it, and that's, true for the skin more than anything else. It's on your skin. You can see skin cancer, so if you can treat it early, most skin cancers are treated. And that's also true for melanoma. Most melanomas are caught early and treated early, and we remove them, and end of story. But obviously, when skin cancers do advance, and it might be the minority of patients, but obviously when that happens, it's very significant, and that's where these will be used in oncology. So he's going to talk to you a lot more about that. So I don't have any relationships with industry. I don't have any conflicts to disclose. I am a member of the board of directors of the American Board of Dermatology, but that's not relevant to anything we're talking about today. So the hardest part of this was being asked to talk about skin cancer. That's easy, but then doing it in about 20 to 25 minutes, that's not so easy. Because we could talk about any of these topics for a few hours. So I'm going to try to condense this to what is hopefully most relevant to you and what is going on. So I picked a number of topics. The column on the left is basically most on the questions that some of you submitted, and I kind of grouped them together. These were kind of the categories that I came up with. We're going to just go through a little bit of Skin Cancer 101, which I think is always helpful to set the stage. A little bit about incidence, what causes skin cancer. Those are oftentimes recurring questions. There were a lot of questions about genetics, family history. My mom has had skin cancer. Some family members had skin cancer. What does that mean for me? I'm going to try to shed some light on that. Of course, we'll talk a bit about sunscreens and sun safety, and then there are also questions about early detection, what we're doing at Michigan Medicine, and what are some of the exciting things that are going on. I'm going to focus on everything but melanoma, and Dr. Lara will talk to you about the advances that are happening in melanoma. So, Skin Cancer 101. Let's start with Skin 101, I guess. I just turned it off. There we go. So if you've heard confusing stories about how many layers of the skin are there, some people say there are 3, some people say there are 7. It's like, what's the right number? Well, both are actually true. It just depends on whether you're a lumper or a slitter. In reality, there are, and I tend to be a lumper, so I'm going to go with that, but there are really 3 main layers, the top layer being the epidermis. That really forms the barrier of our skin. That is really the topmost layer. The dermis is really what gives it the structure. If you think of leather, that's the dermis. And then the hypodermis, or what is below the dermis, is the subcutaneous fat. It's a layer of fatty tissue. And so those comprise really the 3 main layers of the skin. The epidermis can be divided into 4 different layers, the dermis into 2 different layers, and that's how you get to 7. So I'm going to just move from the top of the skin down. So this very top layer here, it's called stratum corneum, is actually, it's a dead layer of skin. Those skin cells have no feeling. If you have a callus, that's what that is. So really the first layer of live cells, if you will, are here in the epidermis. These cells are referred to as keratinocytes, and it just means those are skin cells. And the keratinocytes in this layer of the skin can give rise to a very common type of skin cancer called squamous cell carcinoma. It's not the most common, second most common, but it is the one that arises from this layer of the skin. Slightly lower is the most common type of skin cancer, that is basal cell carcinoma. So it also arises from what we call a keratinocyte, and all these cells are keratinocytes. But it is the cells that are located right there at the base of that epidermis, which is why it is called basal cell carcinoma. So they are both keratinocytes, except one is at the base and the other one is slightly higher than that. So this is a relatively new term that you may not have ever heard of. It's starting to get traction, at least in the the dermatology literature, because it's a much better name than you may have heard the term non-melanoma skin cancer, which is a terrible name because it's anything but melanoma. But really, when people use that term, they're referring to basal cell and squamous cell carcinoma, but there's so many more. So typically, now when we try to talk about the combination of basal cell and squamous cell carcinoma, we talk about keratinocyte carcinoma. That's where that term comes from. Melanoma, number 3 in that list. if you can see, so they're located in the same location, but they're very different cells. When they develop into a cancer, we refer to that as melanoma. So all of these three, again, different skin. So and that kind of gets to one of the main questions that people often ask, if can a basal cell turn into a squamous cell carcinoma? Can a squamous cell turn into a melanoma? The answer is no. These are very different. They arise from different cells. They're apples and oranges. A basal cell is never going to turn into a melanoma. And then lastly, you heard Barb talk about this a little bit. I'm going to just focus your attention on this a little bit, and I'll show you why in a moment. It's a very rare type of skin cancer, but we are a large, one of the very few centers of excellence for this, so it plays a big role in what we do every day. There's no arrow here, because we don't know. Actually, and that's strange. It's called Merkel cell carcinoma, and for those of you who have remember your biology day, there are actually normal Merkel cells in the skin. They're involved with the touch sensation. I was always told if you put your hand in your pocket and you can feel whether something is sandpaper, whether it's cotton, that very fine touch, actually our Merkel cells help with that. This cancer looks like those Merkel cells, but the cells are in this area, so look into that perspective. Lots of questions about the incidence and how frequently do we see skin cancer, how often do they occur. So just to put things into a perspective, so this is the global incidence of neoplasms, and neoplasm just means growth. It doesn't mean cancer, it just means a growth. So any can be a benign growth, it can be what we refer to as an in situ growth, and that just means that it hasn't grown out of the layer where it developed. So if you look at all growths that happen globally, you can see that benign growths are, as luckily, are the number one, but basal cell carcinoma is number 2 in this list globally. So when we talk about basal cell being the most common form of cancer, it is the most common form of cancer, not just the most common form of skin cancer, it is the most common form of cancer. And these numbers, of course, are a gross underestimate. There's no way that we can count every basal cell that is diagnosed in the world. So, but it just gives you a sense of proportion, compared to lung cancer, breast cancer, colon cancer. So here is cutaneous, just means skin. So skin is squamous cell carcinoma, and you can see way down here is melanoma. So just, again, the absolute numbers are not so important, but it's really more kind of the difference in those two, and that's pretty consistent. This is an interesting slide as far as what's happening in the world right now. To understand this, you kind of have to look at this scale here. And this just means that everything that is going towards red means that there is a more significant increase in the number of, and this is keratinocyte carcinoma, so basal cell and squamous cell carcinomas. And blue means that there's a decrease in the number. Well, there's not much blue, as you can see, in the world. The largest increases are in these countries. I have no idea why Trinidad and Tobago is seeing more skin cancers, probably because there are more Caucasians moving there, honestly. China probably has a lot to do with the fact that industrialization has happened there and just their exposure has been different. But I think the key message here is that most countries, especially European, US countries, are in that orangish range. And that means that there continues to be an increase in the number of skin cancers, really, as you can see, worldwide. So this is just to kind of bring that back home and talk about what's happening in the US. Again, the absolute numbers are, these are more accurate than the global numbers, but as you can see, it's that same pattern. So probably somewhere between 4 and 5 million basal and squamous cell carcinomas diagnosed every year in the US. Much fewer cases of melanoma, and actually about half of those are what we refer to as in situ melanoma. Again, the ones that are just in the top layer of the skin. For invasive melanoma, it's about half of that, so around 110,000. Merkel cell carcinoma, the one that I keep bringing up, as you can see, very different number, only about 3,000 a year. But, and I'll get back to the topic of keratinocyte carcinoma, but this Merkel cell carcinoma, why do I keep talking about it? Well, 2 reasons. One is that, as rare as it is, it is increasing just like all other skin cancers. This is kind of where we are right now. This is the projected growth over the course of the next few years. Really, 2025 is really not that far away anymore, which is crazy. But probably the main reason why we focus so much of our attention in Ann Arbor on Merkel cell carcinoma is what it can best illustrate with a picture. I don't have too many examples of these, but this was a patient who was referred to us. This was a picture that was taken at the time of his biopsy, and it showed a Merkel cell carcinoma, and it's this little red dot there. By the time the biopsy was done, it was sent to the lab, the report came back, the patient was referred to us, we got all the paperwork, 5 weeks went by, and that's what happened. So not every Merkel cell behaves that way, but this is actually pretty typical. So if something behaves that way on the skin, you can imagine what happens systemically. So that is, even though it's very rare, this is what gets our attention, and that's why we focus so much attention on it. So I'll come back to that a little bit later. So this increase in incidence that we keep talking about, why is that happening? Well, in reality, there are lots of reasons for it. But there's some pretty significant things that have happened in the last century that we don't always think about. The most important one is, and many of you at this point know this, a century ago, not only was it not chic to have a tan, it was quite the contrary. Having a tan meant that you had a low-paying job for which you had to go outside, and that's what gave you a tan. So if you were somebody of a higher status, you could work indoors, and so being pale was a status symbol. I don't know whether this is entirely true, but a lot of it is attributed to Coco Chanel, who in the 1920s, and the story goes that she was on a train ride somewhere in France, and sitting on one of these back balconies and got a lot of sun, developed a tan, and thought, hey, this actually doesn't look so bad. The point is that she kind of coined that whole notion that having a tan was a fashionable thing. And so it really kind of started in the 1920s. It's not just the bikini, but I don't need to tell you that the square inches of skin that are exposed today compared to a century ago is very different. So, and the more skin that is exposed to sun, obviously, the more likelihood of you developing something. This happened in kind of the 70s when the tanning booth industry really became big. And the idea is let's take as much skin as we can and bombard it with as much ultraviolet light as we can. Right? I mean, that's the concept of a tanning bed. So it's played a significant role. There's no question about it. It's a powerful industry. They have a powerful lobby. It's amazing to me how it's still hard to regulate that. But it's not all of these are components of the story. So again, kind of going back to the clothing story, this is a picture taken in the early 1900s. Railroad workers on the west side of the U.S. Just looking at the picture, looking at the dry sand and the grass, and just the way it's hot. You can tell it's hot. How much skin do you see? None, right? I mean, other than their faces and their nose. So it's that difference in social behavior, and that probably has played the biggest role over the past century. Why we're seeing so much more. People didn't have money to go to Aruba and get sun, and so things have changed in many different ways. And so that is probably a big part of this. So, is it just sun? No, it's not just sun. There are other things that play a role as well. There are a few other things, but really it's a small number. For basal cell, and it's a little different for all skin cancers. For basal cell, probably the biggest other one other than sun is radiation therapy. Most of the time that's not relevant because the lag time between the damage and the development of skin cancer is many, many years. So if somebody in their 70s gets radiation therapy for their prostate cancer, it's going to take several decades to develop skin cancer. So radiation oncologists don't worry too much about it. The patients that we see are those who, and this is really it wasn't until the 1950s when radiation was really very new and was kind of used for everything. It was used for acne. And some of you may remember this. There are people who had their faces and their backs treated with radiation for acne. It worked, but we are still seeing those patients decades later because they're developing specifically basal cell skin cancer. Squamous cell carcinoma, there are some other ones. Arsenic is one that's not really a main issue anymore, but it predisposes to squamous cell carcinoma. The skin cancer that can develop, and you sometimes hear this in chronic wounds and old scars, is also squamous cell carcinoma. Melanoma, there are, other than ultraviolet light, no other environmental triggers that we know of, but there are definitely genetic mutations we'll talk about in just a moment. For Merkel cell carcinoma, it's a combination of either ultraviolet light or exposure to a particular virus, and we won't get into too many details there. But this really is what accounts for the vast majority of all skin cancers. And it is the combination of these two things. It is the combination of the ultraviolet exposure, whether that's from the sun or whether that's from a tanning booth or however you get the ultraviolet light. But that light, that ultraviolet radiation, has to be able to do its damage. The skin has an ability to protect itself from that damage. And it does that by producing pigment. That's actually why you develop a tan. That is the body's reaction to the damage of ultraviolet light. So these melanocytes produce pigment that actually form like little umbrellas, if you will, over the cells to protect the DNA from UV light. It's really, that's how it works. So the more melanin you have, the more pigment you have, the more you are protected from the rays of ultraviolet light. The less pigment you have, and looking in this room, the level of pigment is pretty low, the more you are susceptible to ultraviolet light. So it is really this combination. So are we in Michigan the place that has the most sun in the world? No. But we certainly have a good combination of these two things, and that's really what predisposes particularly people in, like Michigan, to lots of skin cancer. And so these are kind of the people that I would refer to as the poster children for skin cancer. And as you probably know, John McCain had melanoma, Jimmy Carter had melanoma. I think Dr. Lau was going to talk to him as well. She is like the poster child for somebody who later on in life is going to develop melanoma. She's outside, she's playing softball. That's how it happens. So a little bit about the genetics, and try to demystify this a little bit and hopefully answer some questions. So when you talk about, because this is oftentimes a question that comes up, what is my risk of skin cancer if my father had skin cancer and all that? So you have to kind of separate this and just kind of get in a little bit of detail here about germline mutations and somatic mutations. What's the difference between that? A germline mutation is a mutation that is in the cells of the embryo. It is that one cell that you get from your mom, the one cell that you get from your dad, and that cell has this particular mutation, and because of that, as the cells divide, all of the cells in your body are going to have that mutation. A somatic mutation is a mutation that occurs in one single cell because of something. In our case, it's ultraviolet light. So a skin cell that gets ultraviolet light is maybe mutated, the gene may be mutated, and that may develop to a skin cancer. So how is that important? So there are certain syndromes, and they're quite rare, actually. It's important to know they're quite rare, where you inherit a gene from your mom or your dad that, for whatever reason, and we can go over the details, but for whatever reason, are going to predispose you to basal cell carcinoma or squamous cell carcinoma or melanoma. Those do exist, but it's actually a really small number. So for instance, Gorlin syndrome, which is a syndrome that is inherited and increases your chance of developing basal cell carcinoma. So these patients start developing basal cell carcinoma in their teenage years, and they develop many, many more over the course of the year, but it has nothing to do with sunlight. So there are a few of those, but it's really very rare. Most skin cancers are caused by these somatic mutations, so a mutation that occurs in a skin cell because of some type of environmental factor, and again, usually going to be sunlight. And these are kind of the number of genes that have been identified that we know are causing that. But it's important to know that that gene is just in that cancer. So if your basal cell carcinoma has developed because of a mutation in a particular gene, because of the sunlight, what's your chance of developing another basal cell? It has nothing to do with what happened here on the skin. It has to do with the environmental factor that caused that mutation. So, think about this family, okay? He looks like he's what, 35, 32, something like that. 30 years from now, he is going to get skin cancer on his nose. I'm just making that up. Around the same time, she's going to develop a skin cancer on her forehead. They both have skin cancer. Now, these kids are in their late 20s and 30, and they're going to ask me, my mom and dad both had a skin cancer. Am I at an increased risk for developing a skin cancer? The answer is yes, but not because they inherited a skin cancer gene. The answer is because they all have fair skin. They all spent their summers on the beach. They all got sun exposure, and they all had those rays causing those somatic mutations. So yes, there is an increased risk, but not because of the gene that they have inherited. So that's where kind of that
Sorry.
no problem, no. We had a similar occurrence at dinner last night. So that's kind of where, environmental factors and genetics are difficult to separate sometimes. So what do we do about that? How do we decrease this enormous burden of skin cancer that is occurring? Well, sunscreens, right? We talk about all sorts of things. And so for these two, absolutely make a huge difference. If you can prevent that damage, that happens at their age, you can prevent a lot of that. It's not just sunscreen though, it's all of these things. It's just reducing the amount of ultraviolet light that is hitting our skin, reducing the amount of damage that is done. Just kind of my 2 cents on sunscreen. The number that you see on there, that SPF, which is the sun protection factor, what that means is it takes a certain amount of time for your skin to turn red when you're in the sun. And for some people that's very quick, and for other people that's longer. If you put on a sunscreen with an SPF of 2, and you use as much sunscreen as you're supposed to, which nobody does, then theoretically it would take you twice as long to get to that redness. So, but that's not the particular time. That's not 5 minutes or 10 minutes or 2 minutes, because that's different for your skin than it is for my skin. It takes me longer to get red. So that's what that SPF means. So that's why people say like, well, over 30, over 50 doesn't really make that much difference. Well, it depends. If you are very fair skinned, you have red hair, you go outside and with the least amount of sun, you already start to burn. Well, whether it takes you 30 times longer or 50 times longer, actually probably does make a difference. If you're not that sensitive, then that difference is probably going to be negligible. So the point is, go as high as reasonably possible, at least 30. But again, think of how quickly your skin reacts to the sun, and how if you're going to be out in the water, things like that, you want to go higher. So it does make a difference. And all of these things what they're doing is, again, preventing that damage. Now, what about this gentleman? It doesn't take being a dermatologist to see that he's had sun damage. He has freckles, he has little red blotches, he has some spots that are probably from liquid nitrogen because he's had some actinic keratosis treated. Going to make a difference in prevention? Maybe a little bit. Maybe by using sunscreens, we're going to prevent future damage. And it's important to realize that it may prevent future damage, but it's also important to remember that now I get really diligent and I'm using my sunscreen and I'm still getting I'm still getting skin cancer, so the sunscreen is not working. It's working. It's just that you had so much damage before, and that's what's causing that. So it's important to realize that distinction. So this becomes very important. So if we can't prevent it, let's just find it really early, and that's where early detection comes from, so that we can, make a difference. And as I said at the beginning, cure most skin cancers that way. I'm going to just briefly touch on this because this is an area of interest for us, and that's something that I do feel that we need to talk about. We talk about that far too little in medicine, and we really don't talk about it at all in dermatology, and I really think it needs to change. Many of you have probably heard how things have changed, and I'm going to use prostate cancer as an example. 20 years, 30 years ago, every man who developed prostate cancer had radiation therapy or chemotherapy or surgery or a combination of those things. Now, that's changed dramatically. About 40% of men don't have any of those because we know that it is a low-risk form of their prostate cancer, and they're watched carefully, and you can spare them, all of the side effects of the treatment. So if we're okay doing that with prostate cancer, and that has become really kind of the norm, then we really need to think about, if this person develops a basal cell on their nose or on their ear or on their eyelid, needs to be treated. If they develop a little tiny basal cell on their back that they don't even know of, that their dermatologist found, and they're trying to manage their hypertension and their diabetes and all sorts of other things, are we really making a difference in going aggressively after those cancers? So it's an important conversation that I feel that we need to start. I'm going to skip these just in the sake of time. So just want to end with what is going on at Michigan, and in order to do that, I want to just highlight these 3 people here in our department. This is Dr. Kelly Harms. She is, and some of you may know her, she directs our Mohs Clinic, our cutaneous oncology division. She's an associate professor in our department. This is Dr. Anj Dlugosh. He's the associate chair for research and has a strong interest in skin cancer, specifically basal cell skin cancer, but also Merkel cell carcinoma. And Dr. Allison Billy, who is a young junior superstar in our department, and I'll tell you what her interest is in just a moment. So Dr. Harms wears many hats. She's the division chief of, as I said, our Mohs division. She also directs our multidisciplinary skin cancer clinic, and she runs our tumor board, where we see patients with far more types of skin cancer than I just discussed. But importantly, she also manages our skin cancer biorepository. What is that? It's essentially a bank. It's a biobank of tissue, of skin cancer tissue, that we continue to collect, and that is stored, and it is used for whatever research that we end up doing. That was made possible through a generous gift from somebody who actually was not able to come today, but it was through his gift that we were able to do this. And it's a bit of a thankless job, and it's not particularly sexy because all that you're doing is you're collecting these samples, but it's so important for the research that flows from what we're doing afterwards, and Kelly manages that biorepository. Dr. Dlugosh, as I mentioned, he's our associate chair for research, and so he has historically had an interest in basal cell carcinoma. I'll explain this here in a moment. But this was a landmark paper. This was now almost 20 years ago, 2005. This is going to look weird to you, but these are mouse tails.
Oh, no. Yeah.
So just show you the tail. That's a normal tail. That's obviously not a normal tail. And this may look gross to all of us, including me. But when Dr. Dlugosh was able to manipulate the genes in a mouse that created what looked like human basal cell carcinomas, because if you look at the microscope, it looked like a human basal cell carcinoma. That was a huge breakthrough. And that obviously allowed us to study the mechanisms of how basal cell develops, but also look at treatments for basal cell carcinoma. So that was his claim to fame about 20 years ago. He has, and I've been part of that, convincing him to focus his attention on Merkel cell carcinoma for the reasons that we just talked about. And so in a very similar way, again, this will look not so appetizing to most of us, but so just recently, and this has taken 14 years of trial and mostly error, to finally develop mice that are growing tumors that look virtually identical to human Merkel cell carcinoma. And that has, this was published, it made the front page of a very prestigious journal, the Journal of Clinical Investigation. This is April of 2022. And so that has been a major breakthrough to develop these mice. But so the next step is, if we have these cells that are growing these tumors, we can now use cells from those and actually inject them into multiple other mice. Why is that important? Because when we can do that, we can actually start looking at some of the therapies that Dr. Lau is going to talk to you about and see, how they are responding to these therapies. So that is what is going to be the next step. There is where we are actually right now in these clinical trials. The difficulty, as you may imagine, if you start talking about a cancer that affects 3,000 people a year, it doesn't attract as much attention from the NIH, from pharmaceutical companies, because 3,000 people, really? And that's unfortunately how the world works. So it's not easy to get funding for these, but that is kind of where the next step is, and that's where we want to be going. And the reason for that, I'm just going to be brief on this. This is actually melanoma, and this refers to, how, and this is a survival curve, and it essentially means that back in the day, very few people survived melanoma. With some of the treatments that Dr. Lau is going to be talking about, it has gotten better and better and better. But a 50% response rate, which is great, still means there's the other 50% that are maybe not responding to immunotherapy. So these things are critically important, because yes, we have made lots of advances, as you heard, but we still have a long way to go. And then lastly, again, Dr. Alison Billy, who really is a brilliant physician scientist. Her primary interest is not at all in skin cancer, it's in cutaneous lupus. Studying lupus of the skin is doing really well, but she has a side interest in this whole concept of what we are referring to as de-intensification of treatment for low-risk basal cell carcinoma. And we are going to be starting the first trial, it's never been done, just to ask a very simple question. If we take a very low basal cell carcinoma and we watch that person carefully, what is going to happen to that? And every dermatologist in the country knows the answer to the question, but nobody has actually done this study, and nobody's at the moment willing to do it. So Dr. Billy is spearheading that. I'm going to end just with, we do a lot of research, we do a lot of clinical care, but we also teach a lot of residents and fellows. This is our most recent picture of our residency class. So it's the other, the third thing I want to do. I went over my time. I'm going to stop there. I think we're going to have questions at the very end. So thank you for your attention. Sorry to go over.
Is that okay? Yeah. Cool. Hear a little hum. Same. Are we okay?
Yeah.
Anyone with hearing aids here?
Yes.
Yeah, that's probably a bad joke, actually. Okay, well, I'm going to reiterate that just thanking you all for having us here, for Barb, we've been talking about this for a few years, actually, coming up here. So there's some tears who had a lovely evening last night, and really exciting to have you all here and us here to kind of do some education and kind of talk about some of the exciting work. And what I do as a medical oncologist, more kind of advanced skin cancer. So it is hard to do this all in 20, 25 minutes. And I am indeed in that camp that I do believe is potentially curable at this point, and I believe there are people, maybe even in this room, who are potentially cured. So we can talk all about that. These are my disclosures. We do, when I do clinical trials, we do kind of partner with industry. We do these treatments in patients and they provide the medications. And so hopefully, as time evolves, we have kind of a healthy relationship in that way. But these are full disclosure. Okay, so a little bit different take. So I'm, again, mostly going to talk about melanoma. Actually, Ron Jolly's not here, right? Okay, so he interviewed me a couple of weeks ago. And one of his questions was, are this really a big deal? I mean, skin cancer? And I said, yes, but a lot of times it's not. But melanoma in particular, we care about that one because it's more likely to spread than some other cancers. But even basal cell squamous cell, I do treat people who have metastatic stage 4 basal cell carcinoma. In fact, someone who got radiation for their acne, I treated, who had basal cell that spread into their lungs. Also got new treatment, and actually I think he's cured. But if you catch it early, so we stage cancers to give you an idea what the risk is of the cancer. So stage 1 and 2, just in the skin, very highly curable. These are actually before new treatments. We use this kind of 5-year survival. It's a little bit arbitrary, but that's the kind of marker we use. But stage 3, so if it gets into lymph nodes, this is averages, but before new treatments, about a 50% survival. That means 50% of people don't live beyond 5 years. And then in stage 4, less than 5% before these new treatments. And the median survival from stage 4 melanoma before these treatments was 6 to 8 months. So it's a bad disease. Thankfully, the world is changing pretty dramatically. But we'll talk about all of that. So I kind of hijacked this kind of phrase, if you will. So cancer therapy is really in its adolescence, which in general also sounds terrible. But for cancer therapy, adolescence is good. In that, for a long time, we kind of looked at it like we did surgery and radiation and hormones, which kind of a dirty little secret, we're controlling the disease for an extended period, so people living a long time, but probably the vast majority is not cured. But what has changed mostly in the world is immune therapy, so using your own immune system, manipulating that to actually have the disease disappear, and then targeted or this kind of genetic-based therapy. I'm not going to talk too much about that, but also in melanoma, very, very exciting over the last 10 years. I'm going to kind of focus mostly on immune therapy. This is still squeaking, I don't know. But it is stimulating new hope and growth. I don't think it can be overstated. Okay, so I've given a lot of lectures and I've spent a lot of time, a little cocky probably. I'm going to explain immune therapy. It does this and all these genes and diagrams. And I would say the usual response was, oh, that was cool. I have no idea what you just said. And then a colleague said, keep it simple, stupid. So, which I thought was a little harsh, but lesson learned. And then he sent me a slide, which is essentially the Pac-Man theory. Your immune cells, those are your T cells, that when they're activated, they work. That's it. Thanks for coming. So the problem is the cancer is figuring out a way. It's actually, it wants to live, right? So cancer cells figure out a way to live and survive. They do it better than any other cell. So that's a problem for you if it happens to be abnormal and just keep growing and taking over your body. So a lot of smart people kind of figured out ways, why is that tumor, what is the tumor doing to actually block your immune response? And so there's something called these checkpoints or shields, basically, that the cancer puts out to shut down your immune response. And when that happens, you just can't get your T cells to be activated. And guess what? The tumor grows. Turns out that, again, pretty smart people had identified some specific shields. One's called CTLA-4, PD-1, and LAG-3. There's many actually checkpoints, but these are ones that have been identified. And a lot of subsequently developing therapies, optimizing these therapies to basically take down these shields. So these are kind of antibodies that bind to these shields and deactivate them, if you will. And so they disappear. And then it allows those T cells to remain, to engage, stay active, and then kind of tell their friends, and they basically kind of take over not only just where that tumor is, but anywhere in the body as your T cells circulate through your whole body. Crazy exciting time, because it kind of led in melanoma, although it didn't start actually the treatments in melanoma, but since that time, that first discovery, there's been multiple agents actually that have shown a benefit. And it's not just in melanoma. So if your T cells can identify a tumor, and there's a lot of other, it's a little more complicated than that, but there's a potential that that treatment can work, your immune system can work against any cancer. Some people may have heard of these. Keytruda, these are the ones most people have heard of, Opdivo. So these are approved, these are FDA approved for, actually I think it's over 30 cancer indications. And again, I'll show you some of the data. The importance of these is that it can work on a lot of different cancers, but if it works, most importantly, it could be a long-lasting effect. And I think that's where we get into this concept of cure. And there are approvals now also for different types of skin cancer. This is more when they're advanced. So we kind of showed early stage disease, but Merkel cell, they grow so quickly, it also can grow to a point where you can't even surgically remove it, or it spreads internally. And so we've been studying a couple of agents. We actually had a trial combining other things, but there's indications of squamous cell, basal cell, and even in Merkel cell carcinoma. This is just in the skin population. So I think well-deserved. A couple people shared the Nobel Prize for these individual targets that were identified in 2018, Jim Allison, Honjo. Since that time, many of us have kind of worked on these new therapies and again, trying to optimize these therapies, but I think very well-deserved for the Nobel Prize, kind of taken over the cancer in general and the cancer therapy world. So this is in 2023, the FDA approvals now for melanoma. Went from basically nothing. We had high-dose L2 and DTIC actually probably just 10 years ago, or 10-ish years ago. But since that time, 15, 20 new treatments for melanoma, for advanced melanoma. And this isn't just oh, they work a little bit. I mean, it can be pretty dramatic. Actually, we're not going to talk about this at all, but most of this gene is called BRAF, with BRAF mutation. We've developed these treatments that are very, very active actually against that type of melanoma. But these are all the kind of immune therapies that are out there now. And again, like Bichakjian had mentioned, Jimmy Carter actually had stage 4 melanoma. I mean, that wasn't clear. So he actually had it in his brain and his liver. This is well known. Back in 2025. And that was when we first actually got our first approval. The year before was, I'm sorry, 2015. Unfortunately, I think he's on his last days. But turns out it's not for melanoma. At least that's somebody who says. So he had it in his brain and his liver. I told you that the survival, actually when it's in your brain, it's really in the months or 3-4 months. But someone asked me, they said, oh my God, it's too bad, he has cancer. No, it's actually cancer. I said, I actually think he's going to do pretty well. So without knowing any of the other details of that, he actually did really well. And went back to work, he's I think he's going to be 99. And again, he's on hospice, but not for melanoma. Okay, so kind of a specific patient's case. So DT, so in the 1990s, he had a thin melanoma on the side. So a long time later, it actually recurred. So it recurred under his arm. And then we had done staging, it showed up near his kidney. So technically that's a stage, and biopsy proves that's technically a stage 4 melanoma. And like I mentioned, untreated, kind of average it out, it's 6 to 8 months survival. So you can see here, he had this kind of spot near his kidney. So thankfully at the time, these new treatments were being tested. And so he actually had a BRAF mutation, and he was put on a trial. He agreed to participate in a trial. Well, the other options weren't very good. He had this opportunity to have this new treatment, and he was on it for actually some years. It looked like he had a fantastic response. And I was trying to think of this, remember why we had kind of taken him off. It was a long time, these are new treatments. We're we're going to do this forever. What kind of complications you have from these long-term treatments? There's a question. My memory is that we held it. Actually, this is so old that it's from old records. I was trying to pull it out. But in 2016, when we stopped the treatment, we repeated imaging, and it turns out that was still there. Actually, he still had it. But we had therapy that was kind of controlling the growth of that. So certainly beneficial, living a longish life, but still had it. So not untreated, this is going to continue to grow. And at the time, just within those first couple of years, he had an opportunity to get one of the new immune therapies, pembrolizumab or Keytruda, remember. Unfortunately, which I'm also not going to talk about too much, he ran into some complications, which is one of the problems of immune therapy. You can kind of wreak havoc and try to attack the melanoma, but it can attack your normal body. So he had this pancreatitis, so inflammation basically of some of his organs. And had to stop treatment. Turns out there was still something there. We were thinking, so we did radiation. Well, with all of those things done, he had what we call a complete response. It disappeared. And we have followed him over that time, and still nothing. In fact, we kind of we affectionately call this a little schmutz here, which is basically nothing. In 23, based on this PET scan, he still has no evidence of disease, if you can recall, in 2011. And I also know he's doing well, because he's sitting in the back of the room. I have a few other patients here too, which I can also tell the story, with no disease, so that's pretty exciting. I won't call them out, but this is not a one-off. Okay, so this is the survival curve, and again, some people kind of don't like to see these, but this is time on the bottom, so this is months, so over time, and then this is the percentage of people who are alive. So this is for stage 4 melanoma. So back in 2010, this is basically a terrible curve, meaning like less than 5% of people, again, survive. But this is what's happened in the last 10 years. So the overall survival has dramatically improved from that. And actually, if you look at melanoma-specific survival, it's even better. It actually approaches 60%. And we hope with new therapies, it's just continuing to kind of happen. So again, very exciting time. But for people who know me, my kind of tagline is, I'm hopeful but honest. So, and the hopeful part is you see that. There's a chance this thing goes away forever. But the honest part is, it doesn't work for everybody. And so, there's still a lot of work to do here in this population. And this is kind of a personal and professional journey. This is my father-in-law, who at the time was diagnosed with melanoma when I was in medical school. Unfortunately, at the time with no therapy, and he died pretty quickly. And then even this week, or this last week, I had multiple people, unfortunately, still not doing that well. Every week, somebody dying. Last week was terrible. And so that kind of drives me, and I think my colleagues, and I'll try and just continue to try to do better for people. And so really that comes mostly through research. So I'm going to talk about some of the things we're doing in Michigan. But what I do in clinical trials, this really is kind of a global effort. We have colleagues, friends, actually at multiple institutions in multiple nations actually kind of working together for in melanoma. Talk a little bit about microbiome, trying to understand the immune therapy, why immune therapy is a long-term thing, and a little bit about vaccine. We are doing a trial in radiation, although we don't have some of that data. So research people are a little confused by what does it mean, we're going to get a guinea pig or whatever. So there's a bunch of different types. We do it in the lab, to kind of talk a little bit about that. We're trying to find mechanisms, testing that further into animals, unfortunately, in a lot of situations. But I do mostly those kind of treatments in people. But we work together. So there are people who are focused in the lab, and we kind of collaborate with them, do some translation work, if you will. So this is a very complicated slide, but I just want to kind of highlight a couple of things. So one is, someone actually asked me about diet. So the microbiome, if you've ever heard of that, is basically the collection, the population of organisms on your body. Most of those are the trillions of microbes, so they're kind of the external surfaces, so actually on your skin, but also actually your GI tract, all the way through, is actually exposed to the external environment. Turns out they participate in your health. And some people try to manipulate it. You've heard of probiotics and prebiotics. That's basically a way to kind of optimize the bacteria or the microbes in your body. So, so someone was trying to study this in the lab at Michigan, and kind of actually we're giving a variety of different prebiotics. So prebiotics are usually of three types. So fiber, resistant starch, that's the starch that you eat that doesn't get absorbed, it makes its way all the way down, and polyphenols. And the organisms take this up, eat it, and then produce these kind of metabolites, if you will, so these products. So that something called butyrate in particular is kind of anti-inflammatory. In general, it's a kind of healthier situation. So there was a particular type of potato starch that looked like it was the most potent. Weirdly, it's Bob's Red Mill. So, which I ended up starting to take myself and recommend other people. But what was happening is decreasing the inflammation in the gut. We also had some data suggest that the immune system worked better as well. Or even allowing people to get these therapies, like a patient who had to stop because of this inflammation. If he was able to continue, or other people who didn't work for it, they had to stop, but if they're able to continue, maybe it would work better. And so we did a trial actually with people, volunteered to kind of on immune therapy to get this agent to take this. And it's a small study, and we're still analyzing kind of the data from stool actually. but it looks pretty promising. So we're working on better, potentially, prebiotics, and looking to do it kind of more on a larger scale, kind of testing its real therapeutic advantage. So, but this is a very exciting area, and I think most people, it's an area that's kind of growing in interest. How can we figure out why do people do long term? And so there's a colleague actually who is interested in that in the skin, in vitiligo. So vitiligo is, if you didn't know, is a loss of pigment. This particular person, if you don't know them, didn't have melanoma or get immune therapy, but that's just to highlight the vitiligo and loss. Most people look like this, actually, who have kind of an immune response to their skin. It's kind of patchy stuff. Basically, you're losing pigment. Some people get it spontaneously, but a lot of people do get it actually during immune therapy as a, what we call it, kind of almost an on-target effect, meaning like the same cell, the melanocyte, just mentioning, produces the pigment, but it's also the same cell, the melanoma. And so as your immune system attacking melanoma, it thinks your cell, those cells are the same. And so it destroys those cells, and so that's why you get kind of this patchy thing. But Dr. Andrews in particular was interested in saying, why is that, and what's happening in the skin? And so she had actually looked at this so-called resident memory cells. And so one of the thoughts is, so once your immune system is activated, does its job, it goes to sleep. And so there's a population of these T cells that actually become memory cells. So once your immune system works, it has a permanent memory. And some of it is because of these kind of memory cells that sit in the skin, actually, also in other parts of the body. And so it's kind of studying that, or has been interested in studying that, and potentially as a predictor, and we've used kind of the databases that we have, that does look like you can identify those memory cells that also predict survival, like people that are living longer. And so she's now working with patients, volunteering, doing biopsies of their skin in the areas of vitiligo to kind of sort that out and to try to figure out if we can use that to our advantage to say, hey, what can we do with those particular cells? Can we increase the chances of it working, or even do something to help kind of increase that curve for more and more people kind of doing well long term? And then lastly is this kind of neoantigen. So you may have heard about this vaccine. So this is legitimate. I don't know if the vaccine is the best word for that, but it's basically trying to manipulate your immune system to be more specific to that tumor. So neoantigens are basically little short proteins or peptides that kind of sit on the surface that can trigger an immune reaction. But there's so many of them, at least the thought is that there's so many of them that it can't get a robust enough immune response. But if you could pull these neoantigens out and give them to people, you might get actually a better response. The most important part of this is that 85 to 90% of tumors, period, not just melanoma, but colon cancer, breast cancer, prostate, pancreas cancer, will have these novel or new or neoantigens. So if we can figure out how to get your immune system to kind of attack those particular peptides, this could really kind of change the world as far as its therapies go. And Steve Rosenberg was really kind of the godfather of immune therapy, who's still practicing to the day and really has been in the business for decades. Thinks this is probably, if we could figure this out, this will be transformative. And we have the first data really to show that that's possible. And so this is not our work, but we are going to be doing a kind of definitive large trial with Moderna and Merck. And some of the negative part of it, some people just, like this concept of an mRNA, but conceptually, you take out the tumor, you find these neoantigens, you look at the genetic code, if you will, of it, developing these kind of mRNA and actually giving it back to people. So you've heard of mRNA, right? When we give it to it, but this is very specific for those neoantigens. You can give up to, I think it's somewhere between 5 and 34 if you can identify those. They're giving all of those back. So specific and elicit an immune response to that tumor that was in your body. This is for people who had it removed. But theoretically, it should work even if it's still in your body. And the preliminary data showed that it was better actually than Keytruda alone. So it clearly showed I think, proof of principle that you can actually get a better response than even the therapies that we have. So that's exciting. We had a proposal a few years back, and it's still something of great interest, which is the same concept. Only a few groups are really working on this concept, identifying these neoantigens. One of the novel things that we had at least proposed is someone in the Department of Pharmacology built this nanodisc, actually, So part of the problem we've seen is if you just give peptide to people, your immune system doesn't do much with it. But if you can do something to it to have your immune system recognize it, process it, you get a better response. They showed that in the lab, actually. When we're embedding these things in it, it's a dramatic increased stimulation of your immune system. And so the concept was to find these neoantigens. Actually, we have probably the world's leader in cancer genetics or genomics at Michigan. And so partnering with him, finding these novel antigens and giving them back, I think was of great interest. And so then we just injected into people with that same concept. This unfortunately, again, was not funded. It was just a few years ago. I think it was right before COVID, just a giant grant, and so it never went anywhere. Moderna have the money to do it, and so they just kind of did it. And so I think, I do think this potentially would be a better approach, but I do think also many of us are interested in it, and in general, I would say we collaborate to get that stuff done. So we'll see, that kind of is a definitive trial for the Moderna mRNA. Okay, so just kind of wrapping up. So my kind of public service announcement is still like, so first half of my career actually I was interested in a couple grants to do melanoma prevention or chemo prevention. And really, if you really want to impact, which is what I care about, on the cancer problem, you need to approach it kind of multi-pronged, which is really still, like this was saying, prevention, early detection, and treatment. Most of the research we do is in treatment. But the reality is, if you really want to impact overall on the cancer problem, and here I have just for melanoma, we have to do all those other things. So you have to do all of them. So again, like what you do with UV protection or early detection, the skin is the most accessible organ in your body. So you want to screen for, let's say, prostate cancer or breast cancer, which we do have modalities for, but your skin is there. You're looking at it. You should be able to see it, although it's still a little complicated story. But I think doing all of those approaches is really kind of critical. And so I would say 4 simple steps. One is prevention, so UV protection. Chris, again, I had talked about this. I think it's mostly, I had a slide before about behavior. So we still have, you put on sunscreen. Actually, there's some data to suggest when you use sunscreen, there's an increased risk of cancer or skin cancer. That's probably a behavioral issue. Like people will report that they use it, but they don't continue to apply it, or they stay out in the middle of the day when they're exposed to kind of higher intensity. So it's really a behavioral issue that you have to do. And some of it is just kind of staying under the sun or limiting that sun, or like in the beginning part of the day. Number 2 is see your doctor. No more fleas, I don't like looking at them all. Personal health. This is not me, I'm calling Dr. Bichakjian a chimp. Although we're all chimps, right? So, this is an early detection issue, right? So, 3 is monitor yourself. We did a biopsy, turns out it was just a piece of chocolate. So, if you're seeing something you're not sure about, that's either new or growing, you should let somebody know about that and get checked out, or you can just wash yourself occasionally. So better to be safe. And then finally, really, is support research in any way. So maybe they're too easy. We'll talk about mice and research. Just running through bureaucracies and looking for grants, or injecting their tail or something. But for you all, volunteering, it doesn't matter what you do to kind of be a part of that kind of community. Spread the word, vote, or donate, or participating in trials. Actually, we lead that oftentimes with trials, and that people volunteer themselves. We cannot do these trials unless people actually participate in these trials. A patient I mentioned earlier was a part of that trial. The reason we have those answers is because people choose to do it, and they're on these, and it turns out they show benefit, they get FDA approved, and every person after that has access to these agents now that can actually have an impact on their life. So that's just huge for again, improving outcomes in cancer. So, and then finally, we'll keep growing for my adolescents. Thank you. Okay, so we're gonna do a Q&A?
Yes.
Okay, anybody need a break? Stand up, eat your legs. We good? Yes.
One of the words that you had on the left-hand side for prevention was nutrition.
Yeah.
I wonder if you would just talk a bit about that.
So the question is, one of the words I have there was nutrition for skin cancer. So I would say, so when I was interested in prevention, so we looked at a lot of what we call nutraceuticals. And so we've been isolating products. So I had studied curcumin, you've heard of that, turmeric, resveratrol. These are all kind of mostly kind of anti-inflammatories. They have other mechanisms of that. In America, we just kind of take it out and then you take it or you eat it. So I would say, I do think it's important to do that. I think in general nutrition, I think the cancer problem for me is similar to just kind of the major 4 other disorders, right? So there's cancer in general, neurodegenerative disease, like Alzheimer's, stroke, like heart disease. So those are kind of the major killers. I think the common denominator is this kind of chronic inflammatory condition in your body. And I do think diet makes a huge difference. Whether that ultimately would result in kind of less cancer, but if you get injury, part of what you want is to heal from that. You recover, repair those things. I think if you have kind of chronic inflammatory conditions, it's harder to repair those events that have happened. So, but specifically like, you know, a diet that you're gonna eat, like you're gonna eat more curcumin, I don't think that that's the case. Actually, when I studied that, it got a little frustrating because colleagues of mine had studied diet, and so like isolating it, giving it to people, we did trials where we gave like 12 grams of curcumin and tried to see if it changed in the gut, and you really didn't see that. I think it's just your body's so complex. So just taking something like that, I think it'd be really hard to actually make an impact. So I do think of diet in general as an anti-inflammatory, so Mediterranean diet type, I think has been of great interest. So. You want to, Chris? There's a microphone right there too.
Oh, me. Thank you. Those of us that maybe weren't as diligent using sunscreen because we didn't think we had a problem, is there any ointments or salves you can use, to regenerate the skin if it's been overexposed? Not sunburn, but overexposed.
So it's a great question. The question is if we haven't been as diligent with sunscreen, is there something that we can do to regenerate the skin? The short answer is no. Not really, no. It's because there's not a particular event that we know how to fix. Really, what we're concerned about is damage that is done to the DNA in our cells, and if we had a way to fix that, we would be in a different place. I was going to mention something else about sunscreen, so thank you for bringing that up, which I didn't bring up earlier. So yes, because there's questions like, there's controversy like, well, are sunscreens good? Can they potentially do harm? And so there are 2 parts to that. One is, does the actual sunscreen do harm? Can the sunscreen be toxic? And the short answer to that is no, it really is not. There has never been a study that has shown that the ingredients in a sunscreen are going to lead to cancer or cause cancer. There was a recent study that got a lot of attention, I think it was last year, where they showed that when you put on sunscreen, they could detect the sunscreen, certain ingredients of sunscreen in the blood level of people. That's not surprising. Anything you put on the skin is going to be absorbed, is going to be in blood. So just the fact that you can detect it there doesn't mean that it causes anything. So it got a lot of attention, but it was very confusing. The other thing, and that's what Dr. Lau mentioned earlier, is that if there have been studies where they looked at people who used sunscreen diligently, and then a group of people that didn't use sunscreen, and actually found that the people that used sunscreen had more skin cancer. The reason is that the people who were using the sunscreen were in the sun. And people who were not. So, and as I said earlier, like the SPF, that number, if you have an SPF of 20, that means that you have to put more sunscreen on your skin than anybody in their real life, does. So, if you see the number on there, the reality is pretty much just cut it in half. So an SPF of 20, if you put on as much sunscreen as most of us typically do, you're probably getting about an 8 or 10. And so that's the other thing, is that just because it has an SPF of 30, nobody is lathering on as much sunscreen.
If I can just answer your question too, which I don't have an answer for, but that was actually my interest for 10, 15 years, is like, okay, you get an injury, like what are you gonna do about it? you just wait for it to develop. What can you do actually to reverse it? So prevention is a fascinating, complicated thing. It's because you have an event, and then your body might repair it, not a problem, but you have another event. And so, well, what if you're here and it's not quite a cancer, but it's on its way? Like, why can't we do something to reverse that process? And so that was a great, actually that's where the curcumin and these other things were coming in, is that can you actually reverse the damage that's happened? And so, but it was incredibly complicated and difficult to study, so that was my frustrating part, but I think it is a real issue and something I think that would be great if we could figure that out. Do you guys want to call on people?
Mark, about over here.
Yeah.
Mark.
Okay, I'm hiding in the back.
I was curious about your comments about not all basal cells need to be treated and the research going on low-risk basal cell.
I can hear you, but I
Could
can't hear
you,
you.
I'm over here.
Oh, there, okay, yes.
Because my experience is all basal cells are getting treated, so could you say a little bit more about that?
Well, I can talk about that till the cows come home. So the question is my comment about do all basal cell carcinomas need to be treated? And yeah, so I think it is a real question, and it's not a simple question because there's so many variables. But at the end of the day, Dr. Lau and I, when we went to medical school, when we repeated the oath, one line in there is do no harm. And I told this story last night, but I'm going to tell the story again because it really was one of the things that was most impactful to me, and kind of maybe will answer your question a little bit. So I had a patient in Ann Arbor. She's 92, I think, and it was not a basal cell. It was a squamous cell skin cancer, but a very early variant of that. Bowen's disease, squamous cell carcinoma in situ, essentially kind of a notch up from a precancerous spot. So not a dangerous spot. It's on her scalp. They said she was 92, and she was going to have Mohs surgery to have that treated. We're in Ann Arbor, we're in Michigan, and of course this is in January, right? And so she lives in an assisted living facility in Ann Arbor. And the day of her treatment, and we usually start early in the morning, it's like 7:30 in the morning. Of course it's snowing and it's icy. And so she gets up and has a cab, and a cab's going to drive her to the hospital. And you can probably see where this is going. From the door to the cab, she slips and falls and fractures her hip. And so I got the call, Mrs. So-and-so is not coming because she's going to the hospital, she fractured her hip. Well, I felt horrible. I'm like, here I am, making this 92-year-old woman come to see me for a skin cancer that's not going to affect her life. It's an annoyance. It's not going to kill her. And now she fractured her hip, and she's going to go to rehab, and she's going to get pneumonia, and she's going to die of that hip fracture. And as you probably know, a hip fracture in the 90s has a very high mortality. She didn't. Yay. She recovered. She got back home, and she called me and said, I still have the skin cancer. So I said, you're not coming to the hospital. Your assisted living place is on my way home. I'm going to bring I'm not going to do Mohs surgery. I'm going to treat it by simply scraping them. And I went to the nursing home, and I treated the spot on her scalp. So that's what I'm talking about. And so when I bring this up, it brings a lot of controversy. And it's like, what do you mean you're not treating cancer? And it oftentimes gets related to, are you talking about age? Is it like anybody over the age of 85 shouldn't have it treated? What is that age? It has nothing to do with age as far as I'm concerned. I treat many people in their 90s all the time. I have people who come and see me for their Mohs surgery, and their biggest question is, when can I start playing tennis again?
Yeah.
That's the person I want to be treating, because they're going to be bothered by this skin cancer. But I also have many patients who come to me with a diagnosed basal cell carcinoma that they didn't know that they had. It's not bothered them. It's about this big, and it's on their back. But they're coming to the hospital, and they're having this scraped, and they're having this treated, and those are the ones that I'm talking about, and those are the ones that I want us to have a real conversation about. And I've had many patients who have asked me that question, like, well, doc, what's gonna happen if I don't treat this? And when I tell them for this particular lesion, nothing. And then I usually go, well, I didn't know that. Nobody ever told me that. Nobody ever told me that if I didn't do that. So yes, basal cell carcinoma can metastasize, and you can end up seeing Dr. Lau. And that's where, you know, our difference is, because he sees those patients. I see the thousands and thousands of others who are never going to have that. So it's a conversation that needs to be had. So sorry, it's a long answer to your question.
Judgment call.
I think there's a question back there.
So given the specificity of the immune system, the incredible specificity, how about side effects? Unintended consequences in organs are removed from what melanoma primary is?
Yeah, I mean, that's a major problem. It's part of the interest in doing manipulation of the microbiome to help kind of minimize that. There's no doubt about that. I mean, some of the things, I'm sorry, you asked about side effects of treatment, right? Yeah, I mean, again, the immune system is complex, but you can get this kind of acute inflammatory reaction, which actually have that, and then have your immune cells kind of target these areas. So when they're stimulated, they can have kind of offshoots in it. So it's not that specific. You can get the specific T cells against the tumor, but it still have kind of stimulation of your immune system. So yeah, I mean, we've spent a lot of time talking about potential side effects that can happen. The vast majority of them are reversible, treatable, go back to normal. There are some that kind of persist. So we spend a decent amount of time being proactive and kind of managing it. Some of the newer therapies, the most active agents in combinations are the worst, meaning they're the highest. But more recently, we were studying a combination in the last few years, got FDA approved last year, which actually has a third of those side effects. So those are the things at least we're kind of shooting for. But a healthy respect for side effects, and ideally, you know, some of them we're working hard to try to minimize that. So it does become a thing where you're trying to recommend something that's, again, like one's a little bit better, but the side effects are here, and so ideally, you know, we have a better balance in that, but it does happen. Yes?
I want to talk a little bit about melanoma education. In my own personal experience, I did not understand what made melanoma deadly. The term metastasize had not been used. So what is being done, you know, somebody gets diagnosed with melanoma before it's metastasized, and they don't know that all these symptoms might end up being a metastasized version of melanoma.
Do you want to take that on? So the question is, what about melanoma education? Like, basically trying to describe to people what the risks are of that, and you have that. So it's not just like, oh, it's just skin cancer, cut it off and fine.
Right, what should you look for? If you've got a headache, you understand that might mean you have metastasized tumor.
Sure. Well, I see those patients actually that ends up coming back, so all I can say is, when I tell people, so I see people who have stage 3 gut and lymph nodes, and we watch them a lot of times. So I'll tell them to look for a variety of things. So melanoma most commonly actually spreads to the skin, and then to lymph nodes, and then internally. So we do a combination of that. So you're watching your skin, you're going to your doctor, the dermatologist. A melanoma skin exam is a head-to-toe exam. So most people get a good exam, like, okay, that was an exam. So it's like looking everywhere, through your hair, your backside, your feet. I think they look you pretty thoroughly over. Our folks, I think, just do it kind of twice a year and then once a year for the rest of your life. When I tell people, I said, look, you know, you're looking for, let's say it's in your arm, you're looking for changing spots or lumps, nodules, things like that. And then it's difficult with imaging, so we do imaging because one of the risks is internally. But if you have a stage 1 melanoma, we don't generally recommend because the likelihood of that is very, very low. And so it's only those higher stages where it's more likely, then we kind of mix in imaging into that way, and we're potentially even monitoring it. actually, we're kind of doing that in the Merkel cell group, and it's actually identified some early recurrences with just one blood test. So those are things too. So it's a team approach, individual, loved ones, healthcare providers. Yes?
Just, if I could just, comment on that. So it's a great question. How do we educate people about what can happen? And it kind of relates a little bit to what I was saying earlier, because again, it's a pyramid, right? I mean, there's a huge number of people who develop skin cancer, and a small number of people who will eventually metastasize. So finding that balance when you're taking care of people with early stage disease of not freaking everybody out, and because it's not realistic, because most of them are not. But at the same time, if you're the 1%, like, well, how come I didn't know this, right? So it's very difficult, and one part is education. Dr. Lau mentioned imaging studies, which is something that's a little bit more accepted now. That was a big topic for a long time. If somebody has a melanoma, why are we not scanning everybody once a year to see whether they develop metastases, right? You would be a lot of scans, but you could do that. So there are pros and cons to it, and so it turns out that if you do scans on 100 random people, you're going to find stuff. Some of that stuff is relevant, a lot of that stuff is not relevant. But now somebody who has melanoma, what is that? So now you start prodding that with needles and you try to do biopsies of it, and then that doesn't work and they do something else. So you end up doing a lot of things and creating a lot of fear and anxiety when the risk of it happening is very small. So it's a difficult balance, and you have to look at percentages, but percentages are very hard to apply to one single person.
I think people go back to their primary care physician, and, after a melanoma, like, say you had a little surgery, you had something removed, and then you go back to your primary care physician, and, you have your annual checkups, and, you find you have headaches, or you find you have some other symptom, but it doesn't get necessarily linked to a metastasized melanoma. That's what I'm basically getting at.
Right. No, I totally understand where you're coming from, and so people, end up with a primary care physician, and they may not know that it's related to melanoma. So again, it all depends on what it is that you're looking and what you're trying to find. If for the vast majority of skin cancer patients, what you're looking for are more skin cancers, because that's the most likely thing to happen. As far as developing, finding that melanoma, again, that's trying to assess what the risk is, and that's why there's so much work being done on, how can we really don't have, we have ways in which we try to predict whether, what the risk is of a melanoma metastasizing, but it's still difficult to predict, and sometimes you see recurrences, and you look back and you say, well, why did this particular one that had all the features that we consider favorable, and it still recurred? So it's challenging.
I'm gonna just, this might be a great thing to say, because maybe people won't follow with their doctor, but actually with these therapies, actually with immune therapy, you might actually do better if there's more of it. Like, oh my God, this showed up in my lung, why didn't anybody look? Well, it turns out those therapies should still work and might actually be better, because you need tumor for your immune system to actually be activated. So it sounds kind of terrible, like I don't want people not to go to the doctor, I'll just bring down this headache that I can't get rid of. Yeah, so you do it, it's always a kind of a multi-pronged approach, like listening to your body, talking to your doctor, seeing a dermatologist, but just so you know, these therapies could work even if it's present in the body. In fact, that's probably where it works the best. Sounds weird, it's a completely different paradigm.
Got a question up there.
Both of you talked about preventing UV exposure for prevention. And of course, one of the big sources of UV would be the direct rays of the sun. I take it, what are even some of the artificial sources that we can protect ourselves from for our UV exposure?
So the question is about artificial sources of UV that we need to protect ourselves from. I mean, the big one, of course, is tanning booth light, but that's voluntary, right? I mean, you have to go lie in that booth.
Okay.
Other than that, I mean, there really aren't that many. You know, there's sometimes things that people don't think about. Anybody who is, and I haven't, but my daughters and wife have gotten manicures. They use, you know, UV light to harden the nails. So that is some UV exposure. There's not that many other incidental UV. The sun is by far.
The direct rays of the sun, like during midday, I take it would be the thing to protect ourselves from?
Yes, so no, and I mentioned, yeah, and again, sunscreen is only one of the ways to help that. And thinking of the time of day and the time of year also when the UV exposure is high. So yes, I mean, generally people say between 10 and 10 a.m. and 2 p.m. is kind of when, you know, the sun is the most intense.
What about wearing clothes like those men from 2 generations ago, you know, the long sleeves, the long pants, you know, clothing, hats, right?
Absolutely, yeah, right, yeah. So it is a combination of, it's not just sunscreen, it's not just shade, it's not just clothing, and, you know, there's lots of UV protective clothing out there.
Oh,
You know, everybody has to
Right.
make,
Okay.
when's the last time you had a sunburn through your shirt?
Yeah. Okay, thank you. That's very
There's a
helpful.
question there.
Yeah, I know you guys are talking about advanced types of skin cancer and melanomas. I was a nursing instructor, I'm retired now. But one thing we taught our students was the ABCD way of looking at moles to see if they possibly could be turning into a melanoma or a melanoma. And so I was wondering if you guys are proponents of that, or what should the general public know about something like that?
Yeah, the question is about the ABCDs and melanoma. I didn't talk about that. But again, there's so many things to discuss.
Sure.
So
And I saw that photo, and you know, the photo you had of a melanoma, and that just was, there it is.
Yeah. So to clarify for everybody, so it is a little acronym that would to help you find spots that may look like melanoma. The A stands for asymmetry. So if you cut a mole in half and one side looks different than the other. The B stands for border. So what we like to see is a nice round border and not a jagged edge. The C stands for color. Mostly multiple colors within one mole, especially colors like black and blue, but generally the more colors you see. And then D is where the controversy starts a bit, because that used to be diameter, anything bigger than 6 millimeters, which is the size of a pencil eraser. But we've kind of dropped that because there are melanomas that are less than 6 millimeters, and there are many things that are more than 6 millimeters, not melanoma. And so really D has come to be used for what I think is the most important thing to help identify melanoma, and that is difference. And so the reason why those ABCDs are a bit tricky, the picture that I showed you, again, anybody's gonna look at that and say, that doesn't look right. But many melanomas don't have necessarily those features. The biggest thing that gives it away that it's something concerning is that it is different, it is changing. And so there are 2 ways of thinking of the difference. One is difference compared to the other moles. We always refer to it as the ugly duckling sign, so something that looks different from all of the others, or something that is changing over time. So if somebody has noticed a mole and they say, this looks different than it looked a month or 2 ago, I don't care what the ABCDs are. If it's changing, that's concerning to me. So yes, it's helpful, the ABCDs, but for, I think, kind of change of a mole is the most important one.
Could you address atypical melanoma? I had 2 melanomas, and they were atypical, and no dark spots, no moles. They were lumps, not moles.
That's a can of worms. Atypical melanoma. So that's, so there are, all we talked about are, kind of the classic things. So the main atypical melanoma, I would say, is the amelanotic melanoma. So it's the melanoma that doesn't have pigment.
Caused by gene mutation?
So we don't actually know what differentiates an amelanotic melanoma from a pigmented melanoma. There are two things to that. They're definitely more difficult to diagnose. In fact, they're almost never diagnosed with a thought that it's a melanoma. People think it's a basal cell or something, and it turns out to be a melanoma. But the other part is that that aspect actually, it doesn't change anything. So whether a melanoma is amelanotic or not, it has no impact on its behavior. There are many other atypical melanomas, and what we mean by that, it's not so much that it's an atypical melanoma, it's just, there's a benign mole, and there's a melanoma, and it's this whole thing in the middle. Tumors, growths that our pathologists will tell us, well, it looks atypical, it doesn't quite have all the features of melanoma, but it's not quite normal. Those are the ones that we struggle with, because you want to make sure that you treat the ones that are melanoma, but you also want to make sure that you don't expose people to treatment that they don't need. That's the whole gray zone. But probably the most important one is the amelanotic one.
In the last year, I've had 5 biopsies performed on me. 2 of them turned out to be melanomas. One was in situ, and the second one turned out to be 0.6 millimeters. I don't know if that's stage 1 or stage 2, but not real stage 1. Good. I have a condition that's called too many to count. I have spots all over my body. So it looks like it's going to kind of be an ongoing thing of the ABCDE rules watching. Does that seem appropriate, or is there some point at which the number gets so large that I should go to Ann Arbor and talk to immunology, or am I doing the right thing?
So the question is, you have lots of spots, you've had 2 melanomas, how should you be following up? So we have lots of patients who have lots of moles and spots, and that does make it more challenging. But so again, this has to do with what we were talking about earlier. What is, in your follow-up, what is the main goal of follow-up? And in your case, the main goal of follow-up is finding more skin cancers. You need to see a dermatologist. You need to see a dermatologist probably every 6 months to do that skin exam. And every dermatologist, should be, more than capable of doing that. So we wouldn't be doing anything differently in Ann Arbor. I wish there was something that we could be different, but yes, we do.
Do this. Okay, I'm a baby boomer. It's too late for me with all these brown spots and everything. I'm worried about my grandkids. No sunscreen when we were kids. Okay, there is sunscreen now. My granddaughter that's at daycare, she is lathered with sunscreen every time they go outside. But now my other granddaughter, now in elementary school, they're not putting on sunscreen. They're going out morning and afternoon recess, half an hour or so each. How concerned should I be?
So the question is about your grandchildren and how concerned should you be about their risk of developing skin cancer. So this kind of goes back to what I was saying earlier. I'm looking at your skin, and you're pretty fair. So I'm going to assume, and that may not be the case, but I'm going to assume that they're probably fair too. So that's where that genetic risk comes in. Everybody in your family who has skin that looks like you is going to be at a higher risk for developing skin cancer. And you live here in Traverse City. Many of your family members may or may not live here, and they're kind of exposed to the same sun. So the answer is it's a risk for somebody who has fair skin, who is exposed to sun. And we haven't talked really about the depletion of the ozone layer and how much that effect it has. It's hard to imagine that it doesn't have an effect. I'm sure it does. It's difficult to really put a number on that. But that is exactly the age where, we've talked about this now so many times, prevention, that's where prevention makes a difference. I'm not going to do very much, something, but not that much to prevent me. But for that, for those kids, And it's not as if they, and that's, I mean, that's the flip side. It's not as if they have to live under a rock and that they can't see the sun, right? I mean, that's going the other extreme, and we don't want that either. But preventing particularly sunburns at that age. And yes, if you're outside for, half an hour and you have fair skin in, midsummer sun, yeah, that has an impact. So, but again, sunscreen is only one thing, right? It's also, when is recess? Is recess at 9 o'clock in the morning, or is it at 1 o'clock in the afternoon? How much clothing are they wearing? All those things.
I wondered if you have, or how many statistics you have for people that are 10 plus year survivors of metastatic, stage 4 melanoma.
Not much.
Or is it a young class?
I turned this microphone off, but that's okay. Well, not much, because our first new treatment FDA approval was in 2011. So I do have patients out beyond that with high-dose IL-2, but you're talking about a pretty small number. So we don't have much. Every year we're kind of reporting out the kind of evolving data from new treatments. At best, we're like 8.5 years. But what I didn't really get into too much is the importance of that is it just kind of flattened. It's called what we call flattening of the curve, right? So that you can have a response to it and have it recur, but if you don't recur in those if you have treatment, definitely 3 years, the likelihood of recurrence is a low single digit, 1-2% probably, actually, especially when you're out that far. So it's not zero, but it's incredibly low. And I have had patients, I had one patient recur at 5 years after treatment, but back on therapy, no disease 2 years later. So you can actually potentially even restart therapy, or there'll be new treatments, that we're working on. So it will always be better into the future. So I think it's bright in my expectation to live an otherwise normal life.
Good news.
Yeah.
Actually, one's a statement, one's a question. It seems to me that if you pull this down to grassroots, annual physicals should be more inclusive of body scans. And I don't think I've ever had that in an annual physical with my primary care doctor. Anything that I've seen a dermatologist for was because I looked and found it and it concerned me. But when you talk about targeted therapy versus immunotherapy, how do you choose? Like you talked about the inflammatory responses to the immunotherapy. Does the targeted therapy carry a less risk for that? Or what would be the distinction there where it would make you choose one over the other?
So I have an answer for both those. So the second part is, it's complicated, but bring it down to grassroots, it's immune therapy. So nowadays, we actually have a trial for that where we kind of randomize people about half getting a targeted therapy and immune therapy, and then if it grew, you switched over. And in every parameter, immune therapy is better. So you should start with immune therapy nowadays, 2023. My only comment about that, because I was in the prevention world for a long time, and so there were people trying to do these kind of full skin exams, actually, and it really actually never panned out that actually was prevented, probably because it's still relatively rare cancer, right? So unless you have a family history, a personal history is very important actually, but if you have a family history of that, then a primary care doctor and they don't have time. What do you get, 5 minutes with them? So they're not going to do it, and there's no data yet for it, but it doesn't really make sense that you wouldn't do that or set that up. And so I don't think there's a downside if you have a dermatology say, again, I don't know what the reimbursement is or whatever it would be, you pay out of pocket, but again, a melanoma exam is different. So you have to sit, and they have to know in advance. Again, I'm talking to the dermatology world, but you set aside a time because a full skin exam for melanoma is relatively longer than any other procedure.
Thank you.
So yeah, if I can just make one comment, and we're wearing different hats here, but would it be great if everybody had an annual skin exam? Yes. Do we have enough dermatologists to do that? No, we don't. So it is, again, I hate to bring in reality, and so for us it is, my difficulty is getting to see the patients that we need to see. And that's challenging, right? And unfortunately, if you call and schedule an appointment in our department right now, you'll probably get an appointment in about 2 or 3 months. We do triage that, and it depends on what it is that somebody's wrong with, but we don't necessarily always know that. So there have been studies that have been done in Germany. They've done some large-scale population screening studies, where they actually involve primary care physicians, and they taught primary care physicians in how to use a dermatoscope. It's that little magnifying glass that they use. And so you try to see whether you find melanomas. And so the answer is probably yes, you do find more melanomas. The question, though, is does that actually lead to, better survival of people because you're finding them early? It's actually one of the slides that I skipped over. And it's actually pretty, if you look at that, I showed you these curves, right, of these growing numbers of melanoma. But the number of people that, the mortality of melanoma has actually kind of stayed the same and is now getting better because of what Dr. Lau can do with immunotherapy. It hasn't actually gotten better because we've found more melanomas at an early stage.
When they ask the next
So
question.
it's another area of a lot of discussion.
This might not be applicable, but the seborrheic
Seborrheic keratosis, yes.
is that a precursor to the basal cell?
Yep,
Or
it's completely benign.
is there anything you can do to get rid of them?
Many things you can do to get rid of them. It's just freeze them with liquid nitrogen, you can laser them, you can do all sorts of things, but they're benign growths. Yeah, great question.
I just want to, on behalf of the University of Michigan, thank all of you for coming. We hope you found this informative and illuminating. Dr. Bichakjian and Dr. Lau will be by the fireplace for a little bit now if you have any questions. And of course, we hope you join us on Monday, October 2nd, when Dr. Martin Myers will talk about diabetes and the new treatments and aiming for a cure. And you do need to register online to do that, and you can certainly go to the library website to do that. And again, thank you so much to everyone for coming.